Welcome to the Deep Dive, the show dedicated to transforming just a mountain of information into those crucial, eye-opening insights you need to truly be well-informed.
That's the goal.
Today, we're not just skimming the surface, we're taking a deep, almost molecular dive into a topic that, well, it silently orchestrates massive shifts in energy, mood, and even weight for millions, often leaving us baffled.
Yeah.
We're talking about that tiny butterfly-shaped gland in your neck, the thyroid.
It's truly a master conductor of the body. When it's off, you absolutely feel it. But understanding why takes us on this fascinating journey. And that's precisely our mission today. We're going to equip you with the kind of knowledge usually reserved for, the elite professionals in this field.
That's right. Our guide for this deep dive is KATZUNG's Basic and Clinical Pharmacology, a really trusted source, and we're extracting every single important nugget of knowledge from it.
We really are.
You can expect to master everything from the fundamental biology of how thyroid hormones are produced, right down to the specific mechanisms of action of key drugs and the intricate nuances of patient management. Think of this as your shortcut to truly mastering thyroid health. Get ready for some aha moments.
Indeed. And we should probably start at the very beginning with the thyroid gland itself. This remarkable organ is primarily responsible for producing two essential hormones: triiodothyronine, known as T3, and triiodothyronine, or T4, often called thyroxine. These aren't just any hormones. They're fundamental to your body's symphony.
Right.
They normalize growth and development, precisely regulate your body temperature, and meticulously control your energy levels. What's truly pervasive about their influence is, how they touch virtually every cell and system, from your metabolism to your brain function.
And what's the unsung hero ingredient for both T3 and T4? There's a key component, isn't there?
That would be iodine. It's absolutely critical, making up a significant portion of these molecules, 59% of the T3 molecule, and a whopping 65% of the T4 molecule.
Wow, that much.
Yeah. And this isn't just a fun fact, it's a linchpin. It immediately tells you why even subtle shifts in iodine intake can have massive downstream effects on your thyroid function.
That makes perfect sense. And then there's calcitonin. It's often mentioned with the thyroid, but it plays a different tune entirely, right? It's not the same thing at all.
Precisely. Yeah, while it's secreted by the thyroid, calcitonin has a distinct role, completely separate from T3 and T4. Its job is solely focused on calcium metabolism.
Ah, calcium. Okay.
It helps to lower blood calcium levels, acting as a counterpart to parathyroid hormone. So it's part of the thyroid's repertoire, but doesn't contribute to the widespread metabolic and developmental functions we associate with T3 and T4.
Got it. Okay, so given how crucial iodine is, let's talk about its journey through the body, the iodide metabolism. What are the daily requirements, and what happens once we ingest it?
The recommended daily iodide intake for adults is generally 150 micrograms, which is, quite a small amount.
Really small.
Yeah. However, this need significantly increases during critical periods like pregnancy and lactation, jumping to 200 micrograms. And for children, it can go up to 250 micrograms.
Okay.
Once ingested, iodide is rapidly absorbed, entering what we call an extracellular fluid pool in your body. From this pool, the thyroid gland is remarkably selective. It actively removes about 75 micrograms per day, specifically for hormone synthesis.
Just 75 micrograms?
Any excess iodide that isn't utilized for this purpose is simply excreted in the urine.
So it's a very precise system. But what happens if someone takes in more iodide than needed? Does the thyroid just happily take it all up and go into overdrive, or?
That's where it gets really interesting and quite counterintuitive, actually. You might assume more iodide means more hormone production, right?
Yeah, that would seem logical.
But paradoxically, if iodide intake increases significantly, the fractional iodine uptake by the thyroid actually diminishes.
Oh, okay, it slows down.
Yeah. This is a crucial part of the gland's autoregulation, an internal mechanism to prevent overproduction of hormones. It's an elegant feedback loop, ensuring the gland doesn't swing too far in either direction. This brings us to the famous Wolff-Chaikoff block, which we'll definitely discuss more.
That's a perfect segue into the actual biosynthesis of these hormones. This sounds like a multi-step enzymatic dance, a meticulously choreographed process. Can you lay out the steps for us?
It truly is a complex, coordinated dance within the thyroid cells. So the first crucial step is iodide transport. Imagine the thyroid cell as a well-guarded club.
Okay.
This step involves an intrinsic protein on the cell's outer membrane called the sodium iodide symporter, or NIS. Think of NIS as the bouncer.
Bouncer, right.
Actively ushering iodide from the bloodstream into the thyroid cells, even against a steep concentration gradient, ensuring the gland gets its essential raw material.
And can anything stop this NIS bouncer from doing its job? Are there inhibitors?
Yes, absolutely. Very large doses of iodides themselves can transiently inhibit NIS, which is part of that autoregulation we just mentioned.
Okay.
But certain anions like thiocyanate, pertechnetate, and perchlorate are also known competitive inhibitors, effectively blocking iodide transport. This concept is a key insight because these inhibitors are, used in some rare clinical scenarios and can also be found in environmental exposures.
Okay, so iodide is in the thyroid cell. What's the very next move in this dance? Step 2.
From that first entry point, iodide then needs to cross to the apical cell membrane, the side facing the inside of the thyroid follicle. This is step 2. Iodide flow across the membrane. Here, a second iodide transport enzyme called pendrin takes the lead.
Pendrin.
Pendrin controls the flow of iodide into the thyroid follicle lumen, which is where the next crucial steps of hormone synthesis occur.
Pendrin sounds familiar. Isn't that linked to a specific syndrome? I feel like I've heard that name.
You're right to pick up on that, yes. Pendrin is also found in the inner ear. If there's a genetic mutation leading to a deficient or absent pendrin, it results in a hereditary condition called Pendred syndrome, or PDS.
PDS, okay.
This syndrome manifests as both an enlargement of the thyroid gland, known as a goiter, and sensorial deafness. It's a powerful illustration of how a single genetic defect can have seemingly unrelated yet profound effects across different body systems.
Fascinating how a single protein can do that. So now I've got iodide in the right place, ready for action. What's step 3?
Step 3 is where the iodine truly becomes integrated: oxidation and organification. At the apical cell membrane, an enzyme called thyroidal peroxidase, or TPO,
TPO.
oxidizes iodide into a highly reactive form of iodine. This active iodine then rapidly begins to hook onto specific amino acid residues called tyrosine, which are part of a large protein known as thyroglobulin.
Thyroglobulin, right.
This process forms monoiodotyrosine, or MIT, and diiodotyrosine, or DIT. Think of them as like individual Lego bricks, each containing either 1 or 2 iodine atoms.
MIT and DIT. Got it.
This entire process, incorporating iodine into an organic molecule, is precisely what we call iodide organification.
And TPO is a big target for medications, isn't it? That seems like a key control point.
Absolutely. TPO can be transiently blocked by those very high levels of intrathyroidal iodide we mentioned earlier, another facet of autoregulation.
Okay.
But more importantly for pharmacology, TPO is persistently blocked by a crucial class of drugs called thioamide drugs, which are, central to managing hyperthyroidism. On the flip side, the G expression of TPO is stimulated by thyroid-stimulating hormone, or TSH, highlighting the pituitary's powerful regulatory role in this entire process.
Once we have these MIT and DIT Lego bricks, how do they turn into the actual thyroid hormones, T3 and T4? That coupling must be step 4.
That brings us to step 4, coupling reactions. Within the thyroglobulin protein molecule, 2 DIT molecules combine to form the T4 hormone.
2 DITs make T4.
Right. And for T3, 1 MIT molecule combines with 1 DIT molecule.
MIT plus DIT makes T3.
This coupling creates the active thyroid hormones. It's important to note that while other proteins in the gland might get iodinated, only those within thyroglobulin that undergo these specific coupling reactions actually have hormonal activity.
Okay, so once the hormones are formed within thyroglobulin, how are they actually released into the bloodstream for the body to use? That's step 5, right? The final step in this intricate biosynthesis.
Exactly. Step 5 is hormone release and reutilization. The T4, T3, and even the uncoupled MIT and DIT are released from thyroglobulin through a process involving exocytosis and proteolysis, which happens at the apical colloid border.
Right.
This proteolysis, too, can be blocked by very high levels of intrathyroidal iodide, another layer of internal control. Interestingly, the thyroid gland primarily produces T4 directly, an approximate 5.1 ratio of T4 to T3 within thyroglobulin.
5 to 1 T4 to T3.
Yes. This means most of the hormone directly released from the thyroid is T4.
But then we often hear about T3 being the more active form. So where does most of that come from if the thyroid mostly releases T4? That seems like a mismatch.
That's a critical insight, and is key to understanding thyroid hormone activity.
Yeah.
A massive 80% of the T3 circulating in your blood is actually derived from the peripheral metabolism of thyroxine, meaning T4 is converted into T3 outside of the thyroid gland in various tissues throughout your body.
Yeah, okay. So the conversion happens elsewhere.
Right. Only the remaining 20% comes from direct thyroid secretion. And for maximum efficiency, the gland is incredibly good at recycling. The MIT and DIT that are released but not coupled are deiodinated within the gland, and their iodine is reutilized for synthesizing new hormones. It's a beautifully efficient, self-sustaining system.
Wow, really efficient. Okay, so the hormones are made and released. Now, how do they travel through the bloodstream to get where they need to go and act on cells? That brings us to the transport of thyroid hormones. How does that work?
In the plasma, T4 and T3 are reversibly bound to proteins, primarily to thyroxine-binding globulin, or TBG. This binding acts like a vital reservoir, ensuring a steady, protected supply of hormones throughout your body. However, it's crucial to understand that only a very small fraction of these hormones actually exist in their free form, about 0.04% of total T4 and 0.4% of total T3.
Tiny fractions.
Very tiny. These free forms, FT4 and FT3, are the biologically active ones. They're the ones that can actually get into cells and do their work.
So the total levels might fluctuate due to these binding proteins, but it's the free hormone levels that really matter for the body's function. How does the body keep those critical free hormone levels in check? There must be some control.
That's where crucial feedback control comes in. Despite various physiological states, certain pathologies, or even drugs affecting the total T4 or T3 levels, the actual levels of free hormone generally remain remarkably normal. This intricate feedback mechanism ensures that the body maintains a stable, biologically active supply of thyroid hormones, preventing either overt hyperthyroidism or hypothyroidism from developing due to simple protein fluctuations.
That makes perfect sense. Now let's dive into how T4 gets converted into that more potent T3 and also how these hormones are ultimately inactivated in the body. This is the peripheral metabolism of thyroid hormones, right? Another crucial part of the puzzle.
Absolutely. The primary pathway for T4 metabolism outside the thyroid gland is through a process called deiodination. This is carried out by three specific 5-ergodeiodenase enzymes labeled D1, D2, and D3.
D1, D2, D3, okay.
This is where T4 really gets activated or inactivated depending on which enzymes at work.
So how exactly does T4 turn into T3, the more potent form? Which enzyme does that?
By removing a small part of its outer structure through monodeiodination, T4 is transformed into 3000-5000 triiodothyronine, which is T3. T3 is significantly more potent than T4, about 3 to 4 times more so.
3 to 4 times, wow.
Yeah. D1 is responsible for about 24% of the circulating T3, but D2 is the major player, generating a whopping 64% of peripheral T3. Critically, D2 also precisely regulates T3 levels in sensitive areas like the brain and pituitary.
And I recall reading about a genetic variation with D2. How does that impact things for some people?
Yes, that's a key insight for understanding patient variability. A common genetic polymorphism in the D2 gene can actually reduce T3 activation.
Reduce it.
Yeah. This means some individuals might not effectively convert T4 to T3, potentially impairing their response to standard T4 replacement therapy, even if their T4 levels look normal. This can lead to persistent hypothyroid symptoms for some individuals, despite treatment.
That's really important for personalized medicine. And what about reverse T3, RT3? That sounds like an inactivation pathway.
It is. D3 deiodination produces 3003-triiodothyronine, which is known as reverse T3, or RT3. This form is metabolically inactive, essentially a dead-end metabolite.
Inactive, okay.
Both T3 and RT3 have low serum levels in normal individuals because they undergo very high metabolic clearances. They're quickly processed and removed from the system, preventing accumulation of active or inactive forms.
Are there drugs or conditions that can mess with this deiodination process, impacting the balance of active hormone? Because that could cause problems.
Absolutely, and this is a critical clinical consideration. Several factors can inhibit the 5-deiodinase enzyme, leading to lower T3 levels and consequently higher RT3 levels in the serum.
Like what?
Key examples include drugs like amiodarone, often used for heart rhythm disorders, iodinated contrast media used in imaging, certain beta blockers like propranolol, and corticosteroids. Even severe illness or starvation can inhibit this enzyme, showing how interconnected our body's systems are and how overall health impacts hormone activity.
It's clear that the thyroid is meticulously controlled. Let's talk about that regulation, starting with the thyroid-pituitary relationship, the central command center, so to speak, the HPT axis.
Right, the hypothalamic-pituitary thyroid axis. This is the classic feedback loop, fundamental to understanding thyroid regulation. Your hypothalamus in the brain acts as the ultimate master controller, secreting thyrotropin-releasing hormone, or TRH.
TRH from the hypothalamus.
Yes. This TRH then travels down to your pituitary gland, stimulating it to synthesize and release thyroid-stimulating hormone, TSH.
TSH from the pituitary.
TSH, in turn, acts directly on the thyroid gland, prompting it to synthesize and release T4 and T3.
And then the T4 and T3 feedback to complete the loop, effectively telling the brain whether enough hormone is being produced, right? Like a thermostat.
Exactly, like a thermostat. T3, being the more active hormone, exerts a powerful negative feedback on both the pituitary and the hypothalamus. At the pituitary, it blocks TSH action, signaling enough. At the hypothalamus, it inhibits TRH synthesis and secretion, further turning down the command signal. This self-regulating system strives to maintain stable hormone levels, keeping your body's systems in balance. Of course, other hormones or drugs can also subtly influence TRH or TSH release, adding layers of complexity.
Beyond that central axis, does the thyroid gland have any kind of self-regulation independent of TSH from the pituitary? Like, can it control itself?
It absolutely does, and this is known as autoregulation of the thyroid gland. These are intrinsic intrathyroidal mechanisms, primarily linked to iodine levels. One critical phenomenon is the Wolff-Chaikoff block.
The Wolff-Chaikoff block, okay.
This is a crucial insight. When the thyroid gland is exposed to very large doses of iodine, it actually inhibits iodide organification and proteolysis within the gland. It's essentially a self-protective mechanism, temporarily slowing down hormone production to prevent an iodine overload from leading to excessive hormone synthesis.
So too much iodine can actually cause hypothyroidism. That seems incredibly counterintuitive given how vital it is.
It can, yeah, and this is the profound clinical implication.
Mm.
In certain susceptible conditions, like Hashimoto's thyroiditis, this Wolff-Chaikoff block can indeed inhibit thyroid hormone synthesis and lead to transient hypothyroidism.
Wow.
Conversely, in individuals with certain pre-existing conditions like multinodular goiter, the loss of this Wolff-Chaikoff block, meaning the gland no longer responds to high iodine by slowing down, can lead to an exacerbation of hyperthyroidism.
So it can go either way depending on the person.
Exactly. It's a delicate and powerful balance, showing how the same element, iodine, can have dramatically different effects depending on the context.
And finally, when the body creates its own stimulators that mess with this regulation, specifically in a condition like Graves' disease, what happens? How does that work?
In Graves' disease, it's an autoimmune disorder, meaning the body's immune system mistakenly attacks itself. Here, specific immune cells called lymphocytes secrete an antibody known as TSH receptor stimulating antibody, or TSHR-ABSTIM.
TSHR-ABSTIM, okay.
You'll also hear it called thyroid-stimulating immunoglobulin, or TSI. What's fascinating here is that this immunoglobulin binds directly to the TSH receptor on the thyroid gland and constantly stimulates it. It mimics the action of TSH, but with a much longer duration.
Longer duration.
Effectively putting the thyroid into permanent overdrive, driving the overactivity seen in Graves' disease.
And this antibody also plays a role in the distinct eye issues seen with Graves', doesn't it? The ophthalmopathy.
Yes, that's a direct connection. TSH receptors, along with another important receptor called insulin-like growth factor 1 receptor, IGF-1R, are also found in the orbital fibrocytes, the cells around the eyes.
Ah, and the eye cells too.
Yeah. The stimulation of these receptors by the TSHR-ABSTIM is precisely what links Graves' disease to ophthalmopathy, causing the characteristic eye symptoms like bulging eyes, pain, and double vision. It's a key insight into the systemic nature of autoimmune diseases.
Wow, so much happening just in the production and regulation of these hormones. To figure out what's actually going on in a patient, we need to talk about the diagnostic toolkit. How do medical professionals actually evaluate thyroid function? What tests do they run?
This is where thyroid function tests come into play, and they provide a comprehensive picture, allowing us to accurately diagnose and monitor. Let's walk through the key tests and what each one tells you. First, we have total thyroxine, T4, and total triiodothyronine, T3.
Total T4 and T3.
These measure the overall amount of hormones circulating, both those bound to proteins and the small fraction that is free. In hypothyroidism, you'd expect these to be low, while in hyperthyroidism, they'd be high. Normal ranges are about 4.8, 10.4 milliliter CGDL for T4 and 5.9, 156 NGDL for T3.
But you mentioned that total levels can be misleading because of protein binding, so the free forms are more important, right, for actual activity?
Absolutely, and this is a critical distinction. That brings us to free T4, FT4, and free T3, FT3. These are the gold standard for measuring biologically active hormone levels, as they reflect what's actually available to your tissues to do its work.
Okay, the free levels.
Their normal ranges are 0.8, 1.4 NGDL for FT4 and 69.371 PGDL for FT3. Just like the total hormones, these will be low in hypothyroidism and in hyperthyroidism.
And what about TSH, the hormone from the pituitary that tells the thyroid what to do? That seems super important.
Thyrotropic hormone, TSH, is arguably the most sensitive and crucial indicator for primary thyroid dysfunction. The normal range is typically 0.45 AC for 0.12 VA-UML.
Mm-hmm.
What's fascinating here is the inverse relationship, which is a key diagnostic insight.
Inverse, how so?
In primary hypothyroidism, your TSH will be high because your pituitary is working overtime, desperately trying to stimulate an underperforming thyroid.
Okay. High TSH means the thyroid isn't responding.
Right. Conversely, in hyperthyroidism, TSH will be low or even undetectable because your thyroid is overproducing and the pituitary is trying to shut it down.
Low TSH means the thyroid is doing too much.
Exactly. The only common exception to this pattern is in central hypothyroidism, where the problem lies in the pituitary or hypothalamus itself, leading to a low TSH despite low thyroid hormones.
Got it. What about tests that look at the gland's activity directly, like how much iodine it's taking up? Is that useful?
For that, we often use the 123I uptake at 24 hours. This test measures how much radioactive iodine the thyroid gland takes up over a specific period, directly reflecting its activity. It will be low in hypothyroidism, indicating a sluggish gland, and high in hyperthyroidism, showing an overactive gland rapidly taking up iodine.
And for autoimmune conditions like Hashimoto's or Graves', there are specific markers, aren't there? Antibodies.
Yes, the antibodies are crucial for diagnosing autoimmune thyroid diseases. We look for antithyroglobulin antibodies, TGAB, and thyroperoxidase antibodies, ETPO,
ATPO, right?
which are very often present in Hashimoto thyroiditis, indicating the immune system is attacking the thyroid. For Graves' disease, the TSH receptor stimulating antibody, or TSI, is the key marker. Its presence is highly indicative of Graves' and explains the constant stimulation of the thyroid.
How do we visualize the gland itself if there's a lump or something we need to check out, like structurally?
An isotope scan with 123I or 99 milli-TCO4 is used to visualize the gland's size and activity. This is particularly helpful in hyperthyroidism to see if the entire gland is diffusely overactive, as in Graves' disease, or if it's a specific nodule driving the overactivity.
Okay, that's for activity. What about the structure itself?
If we're looking more at structure, especially for thyroid nodules or lumps, a fine needle aspiration FNA biopsy is performed. This is for structural evaluation to check for cancer rather than functional assessment.
FNA for nodules. Makes sense. And is there a test that helps monitor for cancer recurrence after treatment, like a tumor marker?
Yes, serum thyroglobulin is primarily used as a tumor marker, particularly for monitoring recurrence after thyroid cancer treatment. Its levels can indicate if thyroid cancer cells are still present in the body after surgery or other treatments.
So combining all these tests gives you the full, comprehensive picture. It's not just one test.
Exactly. These tests are never used in isolation. By looking at their collective results, we can accurately diagnose, classify, and monitor thyroid conditions, allowing us to implement precise and effective management strategies tailored for each individual. That's how the elite professionals approach it, looking at the whole picture.
It's like putting together a very complex puzzle. Okay, now let's talk about the actual thyroid hormone preparations used in therapy. What options are available and, how do they work in the body to replace what's missing?
When it comes to thyroid preparations, we primarily have synthetic options like levothyroxine, liothyronine, and Liatrix, or those of animal origin, such as desiccated thyroid extract. It's important to remember that all naturally occurring thyroid hormones are what we call levo-L isomers.
Levoisomers, okay.
There's also a synthetic dextro-D isomer of thyroxine, but it has significantly lower biologic activity, only about 4% of the L isomer's potency, meaning it's far less effective at correcting hypothyroidism or suppressing TSH, and therefore pretty much never used.
So how well do these synthetic hormones actually get absorbed when taken orally? Because this seems like a really crucial step for effectiveness. You can take the pill, but does it get in?
Absorption is absolutely critical, and it's a major point of vulnerability for treatment success. T4, or levothyroxine, is best absorbed in the upper small intestine, specifically the duodenum and ileum, with an oral bioavailability of about 70–80%. T3, or liothyronine, is almost completely absorbed, around 95%.
Okay, T3 absorbs better.
It does. However, T4 absorption is notoriously sensitive to numerous factors within your gut. Things like certain foods, for example, bran, soy, or coffee, can significantly impair its uptake.
This sounds like a minefield. I've heard about that, and also other medications interfering. This is where real-world medicine gets tricky, isn't it?
It truly is. Imagine taking your essential thyroid medication only for seemingly unrelated everyday items to, sabotage its absorption. Many drugs can interfere, and this is a key insight for JP's case that we'll get back to. Calcium carbonate
Calcium.
is a well-known culprit. Proton pump inhibitors like omeprazole, which reduce stomach acid, can also impair T4 absorption because T4 needs a certain pH to dissolve properly.
Needs acid. Okay.
Other medications, like oral bisphosphonates, cholestyramine, sucralfate, and iron supplements, are also known to significantly interfere. Even gastric acidity and the balance of your intestinal flora can modify T4 absorption. This illustrates the sheer pervasiveness of this issue for patients. Your daily routine can profoundly impact your treatment.
Are there any newer formulations designed to improve this absorption, especially given all those potential interferences, maybe bypass some of these issues?
Yes, absolutely. Branded soft gel capsules and solutions, like Tirosint or Tirosint SOL, have been developed precisely to address these absorption challenges.
Tyrosine. Okay.
These offer faster and more complete dissolution, boasting an impressive 98% bioavailability, and are significantly less affected by gastric pH changes or the presence of coffee.
Oh, that's a big difference.
Yeah. This often leads to more consistent TSH levels for patients. They're particularly useful for patients with excipient allergies, those sensitive to inactive ingredients in standard tablet forms, and anyone struggling with inconsistent TSH despite seemingly adequate dosing.
Once absorbed, how long do these hormones stick around in the body? What about their half-lives? Does that affect dosing?
Their metabolic clearance and half-life are quite distinct and dictate dosing frequency. In hyperthyroidism, the metabolic clearances of both T4 and T3 are increased, meaning they're used up and removed faster, so their half-lives decrease.
Faster clearance in hyper.
Right. The opposite occurs in hypothyroidism, where clearance is reduced and half-lives are prolonged. Specifically, T4 has a half-life of about 7 days.
7 days? That's long.
It is. This is a crucial advantage because it allows for convenient once-daily dosing. T3, however, has a much shorter half-life, around 1 day.
Just 1 day for T3?
Right.
That shorter half-life for T3 makes sense for why T4 is the preferred daily treatment. But what about other drugs that interact with thyroid hormones once they're in the body, affecting their metabolism or transport? More interactions.
There are several important drug interactions affecting metabolism and transport that professionals must be aware of. Some drugs, like rifampin, phenobarbital, carbamazepine, phenytoin, and certain tyrosine kinase inhibitors, increase hepatic metabolism.
Increase liver breakdown.
Exactly. This speeds up the breakdown and removal of both T4 and T3 from the body. Consequently, patients on these medications often require higher T4 dosages to maintain stable thyroid hormone levels.
And then there are drugs that affect how the hormones are carried in the blood on those binding proteins you mentioned, TBG.
Precisely. Certain medications or conditions can alter thyroid hormone transport or binding to TBG. For instance, estrogens, tamoxifen, heroin, or methadone can increase thyroxine binding globulin.
TBG. Increased TBG.
This leads to increased total or bound hormone levels in the blood, but because of compensatory feedback mechanisms, the free hormone levels usually remain normal.
Okay, free levels stay stable.
Right. Conversely, androgens, glucocorticoids, or danazol can decrease TBG, having the reverse effect. Lastly, drugs like salsalates, furosemide, or heparin can displace T3 and T4 from TBG, causing a transient rise in free hormone levels.
It's fascinating how many ways other medications can influence thyroid hormone levels even after they're absorbed. And for those very rare cases where oral therapy isn't possible, perhaps in an emergency, how are they given then?
For parenteral use, when oral administration isn't an option, the intravenous route is always preferred for both T4 and T3, allowing for rapid and direct delivery into the bloodstream.
IV route. Okay, let's move to how these hormones actually work at the cellular level. This is the mechanism of action, right? The microscopic instructions they whisper to every cell. How do they get into cells, and what do they do once they're inside?
The mechanism of action is quite intricate and powerful. Free T4 and T3 first dissociate from their binding proteins in the plasma, then they enter cells via specific active transporters. Key players here include monocarboxylate transporter 8, MCT8, MCT10, and organic anion transporting polypeptide, OATP1C1.
MCT8, MCT10, OATP1C1. Okay, transporters.
These are like specialized cellular delivery trucks, actively moving the hormones across the cell membrane, ensuring they reach their target.
So without these cellular delivery trucks, there could be serious problems. Even if the thyroid is producing enough hormone, they have to get in.
Absolutely. This is a vital insight. Mutations in these transporter genes can lead to a severe clinical syndrome called Allan-Herndon-Dudley syndrome.
Allan-Herndon-Dudley.
It's characterized by mental retardation, muscle weakness, and unusually low serum T4 levels, even if the thyroid itself is producing adequate hormone. It starkly underscores the critical role of these transporters in getting the hormone into the cells where it can actually work.
Wow. Once T4 is inside the cell, what happens then? Is it ready for action, or does it need that conversion we talked about?
Once inside the cell, T4 is converted to its more active form, T3, by the intracellular 5-reiodinase enzyme.
Intracellular conversion. Okay.
This newly formed T3 then makes its way into the cell nucleus, which is where it truly exerts its profound effects. Inside the nucleus, T3 binds to a specific T3 thyroid receptor protein. This receptor is part of a larger family, including receptors for steroid hormones and vitamins A and D, highlighting the fundamental nature of its action.
So it's binding to a receptor in the nucleus. What does that binding accomplish at the very core of the cell? What does it do?
This binding event is crucial because the T3 receptor acts as a transcription factor. When T3 binds, it changes the receptor's shape, allowing it to bind to specific DNA sequences and regulate gene expression.
It changes gene expression.
Yes.
Yeah.
This leads to increased formation of RNA, which then directs the synthesis of specific proteins. For example, it boosts the formation of Na plus K plus ATPase, an enzyme vital for maintaining cell membrane potential and overall cellular energy. This entire process of gene activation explains why the action of thyroid hormones is not immediate. It's evident in vivo with a time lag of hours or even days after administration.
Ah, that explains the delay.
Right. It takes time for new proteins to be synthesized and exert their widespread effects.
Are there different types of these receptors, and do they have different effects in different parts of the body, like tissue specific?
Yes, the T3 receptor exists in two main forms, alpha and beta. These forms have differing concentrations in various tissues. For instance, alpha receptors are more prevalent in the brain, while beta receptors are more concentrated in the liver.
Alpha in brain, beta in liver.
Okay. This difference in distribution may account for the variations in T3's effects across different tissues. It's also worth noting that mutations in both alpha and beta genes have been associated with generalized thyroid hormone resistance, a condition where the body cells don't respond properly to the hormone, leading to symptoms despite normal or high hormone levels.
And can anything interfere with these critical receptors? Environmental factors, maybe?
Unfortunately, yes. Environmental agents, such as polychlorinated biphenyls or PCBs, and even cigarette smoking, can interfere with the normal action of these thyroid hormone receptors.
Smoking, too. Wow.
Yeah. This adds another layer to understanding how environmental factors and lifestyle choices can impact our thyroid health at a cellular level.
It sounds like the body even adapts the number of receptors based on its needs, which is a testament to its remarkable ability to maintain balance or homeostasis.
It does, which is fascinating for maintaining homeostasis. The number of nuclear receptors can be altered under certain conditions. For example, during starvation, the body actually lowers both circulating T3 hormone levels and the number of cellular T3 receptors. This is an elegant adaptive mechanism to conserve energy when resources are scarce.
Amazing adaptation. So when all these mechanisms are working, what are the broad effects of thyroid hormones throughout the body? It sounds like they touch almost everything.
They truly do, acting like the conductor of your body's symphony. Thyroid hormones are responsible for the optimal growth, development, function, and maintenance of virtually all body tissues. When there are excess or inadequate amounts, it leads to the characteristic signs and symptoms of hyperthyroidism or hypothyroidism, respectively. Think of it. If the conductor is off, the whole orchestra sounds discordant.
What are some of those key manifestations across different body systems? Let's compare hyper and hypo.
Okay, let's contrast. For instance, with the skin and appendages, hyperthyroidism can lead to warm, moist skin, excessive sweating, and fine, thin hair.
Hyper, warm, sweaty, thin hair.
Right. While hypothyroidism causes pale, cool, puffy skin and dry, brittle hair.
Hypo, cool, dry, puffy, brittle hair. Got it.
In the eyes, hyperthyroidism can cause lid retraction and exophthalmos, a bulging of the eyes, especially in Graves' disease, whereas hypothyroidism often presents with drooping eyelids and puffiness around the eyes.
And the cardiovascular system, how is that affected by thyroid imbalances? Big impact there, right?
Huge impact. In hyperthyroidism, you typically see an increased heart rate, stroke volume, and cardiac output, which can strain the heart, leading to a risk of high-output heart failure. The ECG might show arrhythmias, like atrial fibrillation.
Fast heart, high output, AFib and hyper.
Exactly. In striking contrast, hypothyroidism results in a decreased heart rate and cardiac output, with ECG signs like bradycardia.
Slow heart, low output in hypo.
Even the respiratory system is affected. You might see shortness of breath and rapid breathing in hyperthyroidism versus slowed breathing and pleural effusions, with CO2 retention in severe hypothyroidism.
So it's not just feeling tired or energetic, but very physical changes too. Across the entire body, it really is systemic.
Exactly. The gastrointestinal system also responds dramatically. Increased appetite and bowel frequency in hyperthyroidism,
Hyper hungry, frequent BMs.
but decreased appetite and often severe constipation in hypothyroidism.
Low appetite, constipated.
The central nervous system experiences nervousness, anxiety, and agitation in hyperthyroidism versus profound lethargy, fatigue, and a general slowing of all mental processes in hypothyroidism. Even your muscles are impacted, with weakness and increased deep tendon reflexes in hyperthyroidism, and stiffness and decreased reflexes in hypothyroidism. It's a systemic effect top to bottom.
And their critical role in development, especially early in life, cannot be overstated. That seems vitally important.
Critically important. Thyroid hormone is absolutely essential for the normal development and functioning of nervous, skeletal, and reproductive tissues. It also powerfully potentiates the secretion and action of growth hormone. This is why thyroid deprivation in early life, such as congenital cretinism, results in irreversible mental retardation and dwarfism. It's a stark reminder of their foundational role in healthy development.
They also have a pervasive influence on metabolism overall, right? Affecting how we process everything.
Yes, their influence is incredibly widespread. They influence the metabolism of carbohydrates, fats, proteins, and vitamins, often interacting synergistically or antagonistically with other hormones. They also affect the secretion and degradation rates of nearly all other hormones, including catecholamines, cortisol, estrogens, testosterone, and insulin. So their impact is truly widespread, affecting the intricate balance of your entire endocrine system.
And it often feels like hyperthyroidism mimics an adrenaline rush or sympathetic nervous system overdrive. Is there a direct connection? Are catecholamine levels actually higher?
That's a really interesting point. Many of the manifestations of thyroid hyperactivity, particularly the cardiovascular symptoms, strongly resemble sympathetic nervous system overactivity, even though catecholamine levels themselves aren't necessarily increased.
Oh, so it's not more adrenaline.
Not necessarily. This is a key insight. Thyroid hormone actually increases the number of beta receptors on cells and enhances the amplification of the beta receptor signal.
More receptors, stronger signal.
Exactly. This means your body becomes much more sensitive to its own natural adrenaline. This explains symptoms like lid lag, tremors, excessive sweating, anxiety, and nervousness, which can often be partially alleviated by adrenoceptor antagonists, like beta blockers. Of course, hypothyroidism presents the exact opposite constellation of effects: fewer beta receptors, less response.
So it's not more adrenaline, but more places for adrenaline to land, essentially, and a louder response. That's a great distinction. Let's talk about the actual thyroid preparations available for therapy, the choices doctors use to bring patients back into balance. What are the options?
Well, we have several choices, broadly categorized as synthetic, like levothyroxine, liothyronine, and Liotrix, or those of animal origin, such as desiccated thyroid.
And I've heard some controversial uses for thyroid hormones. What are they definitely not effective for and could even be harmful? Things people might misuse them for.
It's crucial to state this clearly and firmly. Thyroid hormones are not effective and can actually be detrimental for managing conditions like obesity, abnormal vaginal bleeding, or depression if the patient's thyroid hormone levels are already normal.
If levels are normal, don't use them.
Right. Giving thyroid hormone in these scenarios would simply lead to hyperthyroidism and its associated risks. While there's some very limited emerging evidence suggesting T3 co-administered with tricyclics might offer benefits for depression in specific contexts, it's far from a standard recommendation and requires much more confirmation.
So if we're talking about actual, safe, and effective replacement therapy for true hypothyroidism, what's the gold standard? What's the main choice?
Without a doubt, levothyroxine T4 is the gold standard and the preparation of choice for thyroid replacement and suppression therapy. There are several compelling reasons for this. It's incredibly stable, boasts excellent content uniformity, is low cost, and doesn't contain allergenic foreign proteins that could cause reactions.
Stable, uniform, cheap, non-allergenic. Okay.
Plus, its serum levels are easily and reliably measured in the lab. Most importantly, its long half-life of 7 days allows for convenient once-daily administration, and it has a proven, decades-long record of long-term safety and efficacy.
What about generic versions of levothyroxine? Are they as good as branded ones? Because cost can be a big factor for patients, right?
Generic T4 preparations provide comparable efficacy and are generally more cost-effective than branded ones. They are FDA approved with the expectation that they are substitutable. Recent studies have even supported that switching among generics in patients with residual thyroid function wasn't associated with clinically significant TSH changes, which is reassuring.
So generics are generally okay.
Generally, yes. However, there are those newer branded formulations, such as tyrosine soft gel capsules and solutions, that offer distinct advantages for specific patients, as we discussed earlier regarding absorption. They provide faster, more complete dissolution and superior bioavailability, with less impact from gastric pH or coffee, often leading to lower, more consistent TSH levels. The American Thyroid Association suggests considering these for patients with allergies to tablet excipients or those with known absorption issues.
So T4 is definitely the workhorse. What about liothyronine at T3? Since it's more potent, why isn't it used routinely? Why not just give the active form?
Liothyronine is indeed 3 to 4 times more potent than levothyroxine, but it's generally not recommended for routine replacement therapy. The primary reasons are its much shorter half-life of only 24 hours.
Right, just one day.
Which would necessitate multiple daily doses, making adherence more challenging and leading to peaks and troughs of hormone levels. Furthermore, it's more difficult to monitor the adequacy of replacement with conventional laboratory tests as its levels fluctuate so quickly.
So if T4 is converted to T3 inside the cells anyway, why would we ever need to give T3 directly? It seems redundant, doesn't it?
That's the key rationale for T4 alone. Because T4 is converted intracellularly to T3 by deiodinase enzymes, the body effectively produces both hormones from a single T4 dose, making direct T3 administration usually unnecessary. However, emerging evidence is shedding light on exceptions. Genetic defects or polymorphisms in D2 enzymes, specifically the 392-ALA-DIO2 variant that we mentioned,
The D2 variation.
might lead to insufficient T3 levels in some hypothyroid patients who are only on T4. These patients may continue to experience bothersome hypothyroid symptoms despite seemingly adequate T4 levels, leading to a discussion about adding T3.
That makes sense for individualized therapy in specific cases, but is there any risk with T3, especially given its potency and shorter half-life? Any downsides?
Yes, caution is advised, especially in cardiac patients, due to the risk of cardiotoxicity from significant elevations in peak T3 levels that can occur with direct administration.
Cardiotoxicity risk.
Okay. Because of these factors, T3 is typically reserved for very specific use cases. For short-term TSH suppression, perhaps before certain diagnostic procedures, or for those rare individuals with confirmed unresponsiveness to T4 alone, perhaps due to those genetic variants where T4 to T3 conversion is impaired.
What about desiccated thyroid, the animal-derived preparation? It seems to have a bit of a following among some patients, but medical guidelines often advise against it. Why is that? What are the issues?
Despite some patient preference and its historical use, the use of desiccated thyroid extract, or DTE, is generally avoided in modern practice for a multitude of reasons. The disadvantages are numerous. It carries risks of protein antigenicity, meaning it could provoke an allergic reaction. Its product stability is variable. Hormone concentrations can fluctuate unpredictably from batch to batch.
Inconsistent dosing?
And it has limited FDA oversight compared to rigorously controlled synthetic options. Furthermore, it's difficult to monitor effectively with standard lab tests, even if it appears cheaper up front.
So it's not just a matter of potency, but quality control and safety concerns are the big drivers.
Precisely. DTE treatment often results in a much higher serum T3-T4 ratio than the body naturally produces, leading to the potential for toxic peak T3 levels, especially after a dose. While some studies have found no significant difference in overall hormone levels achieved between DTE, T4, or T3, and some patients indeed prefer DTE subjectively, the general medical consensus leans strongly against its routine use due to these quality control and safety concerns. For historical context, approximate equivalences suggest 60 milligrams or 1 grain of desiccated thyroid is roughly equivalent to 80-100 milligrams of levothyroxine or 37.5 milligrams of liothyronine. But any dosage conversions require very careful retitration based on clinical and laboratory responses.
And what about Leotrix? You mentioned that briefly.
Leotrix is a fixed-dose combination of T4 and T3, available from some manufacturers. There is consensus guidance available for its use in specific situations, but it's generally more expensive and doesn't offer a clear clinical advantage over T4 alone for most patients, similar to the reasoning against routine T3 use.
What about storage and shelf life for these preparations? It sounds like they might be quite sensitive. How should people store them?
Synthetic preparations generally have a shelf life of about 2 years, particularly if stored in dark, airtight bottles to minimize spontaneous deiodination and degradation from light or moisture. For desiccated thyroid, the shelf life is more uncertain and variable, but its potency is better preserved if kept dry.
Okay, so we've covered how the body makes and uses thyroid hormones and how we replace them when there's a deficiency. Now, let's flip the switch. What happens when there's too much thyroid activity, and what drugs do we use to calm that overactive gland? This brings us to antithyroid agents. What's the general idea here?
The general principles of antithyroid action involve either directly interfering with hormone production, modifying the tissue's response to these hormones, or causing glandular destruction through radiation or surgery. A term often associated with these agents is goitrogens.
Goitrogen.
These are substances that suppress T3 and T4 secretion to subnormal levels, which in turn causes an increase in TSH, ultimately leading to glandular enlargement or a goiter. The primary clinical antithyroid compounds we use are the thioamides, iodides, and a radioactive iodine.
Let's start with the thioamides. These sound like the cornerstone of hyperthyroidism treatment. Which drugs are these?
They absolutely are. The main thiamide drugs are methimazole and propylthiouracil, often abbreviated as PTU.
Like methimazole and PTU, okay.
In some regions, carbimazole is used, which the body quickly converts into methimazole, so its effects are essentially the same. Methimazole is significantly more potent, about 10 times more, and is generally the drug of choice for adults and children due to its efficacy and once-daily dosing.
But I've heard there is a serious warning for PTU. Is it still used? What's the issue there?
That's correct, and it's a critical point for any professional to know. Propylthiouracil carries a black box warning from regulatory bodies due to the risk of severe, sometimes fatal, hepatitis.
Liver damage, okay.
Because of this, its use is largely restricted to very specific, compelling situations. It's preferred in the first trimester of pregnancy due to a lower perceived teratogenic risk compared to methimazole in cases of life-threatening thyroid storm, or for patients who experience adverse reactions to methimazole, but critically excluding a granulocytosis or hepatitis itself, as cross-sensitivity can occur. The thiocarbamide group in their chemical structure is essential for their antithyroid activity.
Let's delve into the pharmacokinetics of these thioamides. How are they absorbed, distributed, and eliminated in the body? How do they move around?
Methimazole is completely absorbed, though at variable rates, and is readily concentrated by the thyroid gland, which is key to its action. Its excretion is relatively slow, with 65–70% of a dose recovered in urine within 48 hours.
Okay, methimazole concentrates well, excreted slowly.
Right. Propylthiouracil, on the other hand, is rapidly absorbed, reaching peak serum levels within an hour, though its bioavailability is somewhat lower at 50–80%, possibly due to incomplete absorption or a significant first-pass effect in the liver. Most PTU is excreted within 24 hours as an inactive glucuronide.
Their plasma half-lives seem quite short, yet their duration of action is much longer. How does that work? Why do they last longer than their half-life suggests?
That's a key pharmacokinetic nuance and a crucial insight. Despite short plasma half-lives 1.5 hours for PTU and 6 hours for methimazole, their antithyroid action lasts much longer. This is because both agents are concentrated and persist in the thyroid gland itself.
Ah, they stick around in the thyroid.
Exactly. For example, a single 30-milligram dose of methimazole can exert an effect for over 24 hours, making once-daily dosing effective for most hyperthyroidism, which is a big win for patient adherence. PTU, however, typically requires dosing every 6 to 8 hours to maintain its inhibitory effect on iodine organification due to its faster clearance from the gland.
And what about their use during pregnancy and breastfeeding? This is obviously a very sensitive area. How do they handle that?
Both thiamides cross the placental barrier, classifying them as FDA Pregnancy Category D. This means there's evidence of risk, but the benefits might outweigh the risks in certain situations. Propylthiouracil is generally preferred during the first trimester because it's more strongly protein-bound, which means less of it crosses the placenta.
PTU preferred in first trimester.
Right. Methimazole has been, albeit rarely, associated with specific congenital malformations if taken in early pregnancy. During breastfeeding, low concentrations of both thiamides are found in breast milk and are generally considered safe for the nursing infant, but monitoring is still advised.
Now, for the pharmacodynamics, how do these thiamides actually work at the cellular level to reduce hormone synthesis? What's their main mechanism? How do they stop the thyroid?
Their major action is to prevent hormone synthesis by inhibiting the key enzyme, thyroid peroxidase, TPO. They block the TPO-catalyzed reactions, specifically stopping iodine organification, the incorporation of iodine into thyroglobulin, and they also block the crucial coupling of iodides, meaning MIT and DIT can't combine to form T3 and T4.
Block organification and coupling. Okay.
It's important to note that they do not block the initial uptake of iodide by the gland itself. They only stop the subsequent steps of synthesis.
So they stop production, but not the initial uptake. And PCU has an additional mechanism, right, that methimazole doesn't, something extra.
Yes, this is a distinct advantage of PTU, particularly in severe cases like thyroid storm where rapid reduction of active hormone is crucial. Only propylthiouracil inhibits the peripheral deiodination of T4 to T3.
Ah, it blocks the T4 to T3 conversion too.
Right. This means it not only stops the thyroid from making new hormones, but also actively reduces the conversion of the less active T4 into the more potent T3 in the body's peripheral tissues, leading to a quicker symptomatic improvement.
And since they only affect new synthesis, the onset of action must be slow because there's already a reserve of hormones stored up, right? Takes time to see effects.
Precisely. Because they don't affect existing hormone stores, the hormones already produced and sitting in the thyroid gland, it can take 3-4 weeks for the thyroid's existing T4 stores to deplete before you see the full clinical effect. This is why patients need to be patient with this treatment and why other symptomatic treatments like beta blockers are often used initially.
Let's talk about the downside, the toxicity and adverse reactions associated with thioamides. What should patients and clinicians be aware of, especially the most dangerous ones? What are the risks?
Adverse reactions occur in 3–12% of treated patients. Common ones, often appearing early in treatment, include nausea, general gastrointestinal distress, and with methimazole, an altered sense of taste or smell. The most common skin reaction is a maculopapular itchy rash, affecting 4–6% of patients, sometimes accompanied by fever.
Rash is common. Okay.
Rarer but more severe reactions can include urticarial rash, vasculitis, a lupus-like reaction, swollen lymph nodes, hypoprothrombonemia, a clotting issue, and acute arthralgia, joint pain.
And the liver injury. That was the black box warning for PTU. How serious is that?
Yes, liver injury is a critical concern. Propylthiouracil carries that black box warning for severe, sometimes fatal, hepatitis. Cholestatic jaundice, a different type of liver issue, is more commonly associated with methimazole. It's crucial to stop therapy immediately if liver transaminase levels become significantly elevated, for instance, 2 to 3 times the upper limit of normal, as this indicates liver damage.
And what's the most dangerous, though rare, complication? The one people really worry about?
That would be a granulocytosis, defined as a severe drop in certain white blood cells, granulocytes, below 500 cells.
Granulocytosis. Very low white cells.
Yes. This is an infrequent but potentially fatal adverse reaction occurring in about 0.5% of patients taking thioamides. The risk is higher in older patients, and for those receiving high doses of methimazole, particularly more than 40 milligrams per day, often within the first 90 days of treatment.
What's the management if that occurs? What do you do?
It's usually rapidly reversible once the drug is discontinued, but broad-spectrum antibiotic therapy may be necessary for complicating infections due to the weakened immune system. In some cases, colony-stimulating factors can help hasten the recovery of granulocytes. It's also vital to know that there's about a 50% cross-sensitivity between propylthiouracil and methimazole.
50% cross-sensitivity.
Yeah. This means if a patient has a severe reaction like a granulocytosis to one, switching to the other might not be safe and should generally be avoided. Patients must be instructed to immediately report a sore throat or high fever, as these can be the first signs of a granulocytosis, and then seek immediate medical attention for appropriate blood tests and management.
Okay, crucial safety information. Next up, let's talk about onion inhibitors. How do these work, and are they commonly used? They sound different.
Monovalent anions like perchlorate, pertechnetate, and thiocyanate work by competitively inhibiting iodide transport, specifically blocking the NIS, sodium iodide importer, that we discussed as the bouncer pulling iodide into the cell.
They block the uptake. Okay.
However, their effectiveness is often unpredictable and can be easily overcome by large doses of iodides, which severely limits their practical use.
So not a frontline treatment then, not used much.
Not anymore for routine hyperthyroidism. Potassium perchlorate, for instance, is rarely used clinically due to the significant risk of a serious side effect, plastic anemia. Its main, albeit rare clinical use, is to block thyroidal reuptake of iodide in cases of iodide-induced hyperthyroidism, like that caused by amiodarone, where there's an excess of iodine pushing the thyroid to overproduce.
Let's move to iodides. I know these were historically very important in thyroid management. What's their role now? Do we still use plain old iodine?
Before thioamides became available in the 1940s, iodides were indeed the major antithyroid agents. Today, they are rarely used alone. In pharmacologic doses, generally above 6 milligrams per day, Iodides have several actions on the thyroid. Their primary effect is to rapidly inhibit hormone release, possibly by inhibiting the proteolysis of thyroglobulin, which is the process that frees T3 and T4 from storage.
Inhibit release.
Okay. They also decrease the size and vascularity of a hyperplastic gland, which is a unique and valuable effect.
So they can quickly bring symptoms under control, like in a crisis,
Yeah.
and help with surgery.
Yes. Improvement in thyrotoxic symptoms occurs very rapidly, often within just 2 to 7 days. This rapid onset makes them incredibly valuable in acute, life-threatening situations like thyroid storm. Also, their ability to quickly decrease the gland's vascularity and fragility makes them invaluable for preoperative preparation before thyroid surgery, simplifying the procedure and reducing bleeding risks.
So they sound great for rapid relief. What are the disadvantages or reasons they're not used for long-term management? Why not just stay on iodine?
There are significant disadvantages that make them unsuitable for chronic use. First, iodides dramatically increase the intraglandular stores of iodine. This can delay the onset of thioamide therapy or, crucially, prevent the use of radioactive iodine therapy for several weeks afterwards because the thyroid is full of non-radioactive iodine.
Ah, it blocks RAI uptake.
Right. Therefore, if radioactive iodine treatment is likely, iodides should be avoided or administered only after thioamides have already begun to block synthesis. Second, and this is a major concern, the gland can escape from the iodide block in just 2 to 8 weeks if administered alone.
Escape phenomenon.
Yes. This can lead to a severe exacerbation of thyrotoxicosis in an already iodine-enriched gland, making the problem worse than before. So chronic use should always be avoided.
And pregnancy. Is chronic iodide use safe then?
Chronic use of iodides in pregnancy should also be avoided due to their placental passage and the significant risk of fetal goiter and even hypothyroidism in the developing baby. However, there's very specific and important public health use for potassium iodide, Ki, in radiation emergencies.
Ah, right, for nuclear events.
Exactly. If administered before exposure to radioactive iodine isotopes, such as from a nuclear accident, it can effectively protect the thyroid gland from subsequent damage by completely blocking the uptake of the harmful radioactive iodine.
What about the side effects of iodides themselves? Is there toxicity?
Adverse reactions to iodine, known as iodism, are uncommon and usually reversible upon discontinuation. Symptoms can include an acneiform rash, similar to what you might see with bromism, swollen salivary glands, mucous membrane ulcerations, conjunctivitis, rhinorrhea, runny nose, drug fever, a metallic taste in the mouth, and rarely bleeding disorders or anaphylactoid reactions.
Now, for something that offers a more definitive and permanent solution, radioactive iodine, 131I. How does it work to treat hyperthyroidism? It sounds dramatic.
Radioactive iodine, specifically 131I, is the only isotope used for treating thyrotoxicosis. It's administered orally as a simple sodium 131I solution or capsule. Once ingested, it's rapidly absorbed from the gut. Then, crucially, it's highly concentrated by the thyroid gland, which, as we discussed, avidly takes up iodine.
The thyroid sucks it right up.
Exactly. Once inside the thyroid cells, it's incorporated into the storage follicles, just like regular iodide. Its therapeutic effect relies on the emission of powerful beta rays, which have an effective half-life of 5 days and a short penetration range of only 400 to 2,000 micrometers. Within a few weeks of administration, these localized beta rays cause destruction of the thyroid parenchyma, the working tissue of the gland, leading to epithelial swelling, necrosis, follicular disruption, edema, and leukocyte infiltration. This localized radiation effectively ablates or destroys the overcollective thyroid tissue.
That sounds quite destructive. Is it safe long-term, especially considering its radiation? What about cancer risk?
Despite the initial understandable concerns about radiation, fears of radiation-induced genetic damage, leukemia, and other cancers have largely not materialized after more than 50 years of extensive clinical experience with radioactive iodine therapy for hypothyroidism.
That's reassuring.
Its advantages are clear. It's easy to administer, highly effective, relatively low cost, and it's a painless procedure.
So it's generally safe, but there must be absolute contraindications given the radiation. Who absolutely cannot get RAI?
Absolutely. It is strictly contraindicated in pregnant women because it crosses the placenta and will irrevocably destroy the developing fetal thyroid gland, leading to severe hypothyroidism in the baby. It's also strictly contraindicated in nursing mothers, as it's secreted in breast milk and would expose the infant to radiation. These are non-negotiable contraindications due to the profound risk to the developing child.
Finally, let's talk about adrenoceptor blocking agents, or beta blockers. They don't directly target the thyroid gland, so what's their crucial role in managing hyperthyroidism? Why use them?
Beta blockers, particularly those without intrinsic sympathomimetic activity, like propranolol, metoprolol, and etanol, are incredibly effective therapeutic adjuncts in managing thyrotoxicosis. This is because many of the outward symptoms of hyperthyroidism, tachycardia, rapid heart rate, palpitations, tremors, anxiety, excessive sweating, mimic those associated with sympathetic nervous system overactivity, as we discussed earlier.
Right, the increased sensitivity.
Exactly. While beta blockers don't typically alter thyroid hormone levels themselves, they provide crucial and rapid symptomatic relief by blocking these sympathetic effects. Propranolol has been the most widely studied and used beta blocker in this context. Interestingly, at higher doses, specifically greater than 160 milligrams per day, propranolol may also directly reduce T3 levels by approximately 20% by inhibiting the peripheral conversion of T4 to T3.
Oh, so it have a dual benefit at higher doses.
Yes, it can. So it's really helpful for getting symptoms under control quickly while the other treatments start to work.
So we've covered the body's natural thyroid system and how we manage an overactive gland. Now let's switch gears and focus on hypothyroidism when the thyroid isn't producing enough hormones. How does this deficiency manifest throughout the body? What does it feel like for the patient?
Hypothyroidism is a syndrome resulting from a deficiency of thyroid hormones, leading to a reversible slowing of virtually all body functions. If we refer back to what we know about symptoms, you'd see changes like pale, cool, puffy skin, dry, coarse hair, and a puffy face.
The opposite of hyperthyroidism symptoms.
Exactly. The cardiovascular system exhibits a decreased heart rate and cardiac output, making you feel sluggish. The central nervous system shows profound lethargy, fatigue, slowed speech, impaired memory, and a general slowing of mental processes. Digestion slows, leading to constipation, and overall metabolic rates decrease, often resulting in unexplained weight gain and cold intolerance. It's like your body is stuck in slow motion.
And what's the devastating impact on children and infants if this isn't caught and treated early? You mentioned cretinism.
In infants and children, the impact is particularly severe and tragic, resulting in striking retardation of both physical growth and cognitive development. This leads to dwarfism and, most profoundly, irreversible mental retardation, a condition historically known as cretinism. This underscores the critical importance of early diagnosis and universal newborn screening for hypothyroidism.
What are the main causes of hypothyroidism that professionals look for? Why does it happen?
The etiology of hypothyroidism varies, but some causes are much more common than others. The most common cause in the United States today is probably Hashimoto thyroiditis.
Hashimoto's. Autoimmune again?
Yes, this is a classic immunological disorder in genetically predisposed individuals, where the body's own immune system attacks and gradually destroys the thyroid gland. Initially, a goiter, or enlarged thyroid, might be present, but it can disappear later as the gland is completely destroyed. Other causes include drug-induced hypothyroidism, where various medications block hormone formation, dishormonogenesis, and impaired T4 synthesis due to an inherited enzyme deficiency, radiation exposure or surgical thyroidectomy leading to gland destruction or removal, congenital causes like heteriosis, absent thyroid, or severe iodine deficiency, and secondary hypothyroidism resulting from pituitary or hypothalamic disease, where the problem isn't the thyroid itself but the signals to it.
And how is primary hypothyroidism easily diagnosed in the lab? What are the key test results?
The laboratory diagnosis of primary hypothyroidism in adults is easily confirmed by two key findings: a low free thyroxine, FT4 level, indicating insufficient active hormone, and, crucially, a significantly elevated serum TSH level.
Low FT4, high TSH.
Right. The high TSH indicates the pituitary is working overtime, desperately trying to stimulate a failing thyroid, which is a clear sign that the thyroid itself is the primary problem.
So for management, it's mostly about replacement therapy, right? Giving the body what it's missing.
Correct. Except for drug-induced hypothyroidism, where the offending agent can simply be stopped. The general strategy for hypothyroidism is lifelong replacement therapy. As we discussed earlier, the most satisfactory and universally accepted preparation for this is levothyroxine, whether it's a branded or carefully selected generic preparation.
And you mentioned earlier that generic levothyroxine is often considered comparable, which is good for access and cost.
Yes. Multiple trials have documented that switching among generics, even in persons with residual thyroid function, was not associated with clinically significant changes in TSH levels, offering reassurance regarding their efficacy. Furthermore, While the idea of combination therapy with levothyroxine plus liothyronine, T4 plus T3 has been explored extensively, multiple clinical trials have generally shown it's not superior to levothyroxine alone for most patients.
So T4 alone is usually enough?
Usually. However, it's worth reiterating that genetic variations in deiodinases or hormone transporters, particularly the D2 polymorphism, may account for why some patients continued to experience symptoms on T4 alone, suggesting a need for individualized consideration and discussion in those specific cases.
How do you determine the right dosage for levothyroxine? It sounds like it varies quite a bit depending on the patient. It's not one size fits all.
Dosing considerations are highly individualized and vary significantly with age and weight, which is a critical point for professionals. Infants and children, surprisingly, require more T4 per kilogram of body weight than adults.
More per kilo for kids.
Yeah. For example, an infant aged 1 to 6 months might need 10-15 millikilograms per day, demonstrating their higher metabolic demands. The average adult dosage is around 1.7 millikilograms per day, which often translates to about 125 millikilograms daily. Older adults over 65 may require less, around 1.6 millikilograms per day, as their body mass and metabolic rate naturally decline. Patients requiring post-thyroidectomy suppression therapy for thyroid cancer often need significantly higher doses, about 2.2 millikilograms daily, to completely suppress TSH and reduce recurrence risk.
And what about conditions that might increase the requirement for levothyroxine, even if the patient's weight or age stays the same, things that affect absorption?
Increased thyroxine requirements have been reported in patients following bariatric surgery, which can alter absorption, and in those with other malabsorptive disorders such as atrophic gastritis, Helicobacter pylori gastritis, celiac disease, or lactose intolerance. These conditions can interfere with the gut's ability to absorb the medication. In some cases, treating these underlying disorders can even reduce the necessary thyroxine dose, highlighting the importance of a holistic approach.
This brings us back to JP's case, which we'll revisit. You emphasized optimal administration for absorption. What are the key details there that are absolutely crucial for success? How exactly should people take it?
This is absolutely crucial, and it's an aha moment that can profoundly change a patient's outcome, like JP's. Since interactions with certain foods like bran, soy, and coffee, and numerous drugs can significantly impair absorption, levothyroxine is optimally administered on an empty stomach.
Empty stomach, okay.
This means taking it ideally 30-60 minutes before meals, at least 4 hours after meals, or for some patients, conveniently at bedtime, at least 4 hours after their last meal. This specific timing is essential to minimize interference and ensure consistent absorption, which in turn helps maintain TSH within the therapeutic target range of 0.5 to 2.5 MIUL.
How often do you monitor and adjust the dosage, especially given its long half-life? How long do you wait between checks?
Because of its long half-life of 7 days, levothyroxine permits convenient once-daily dosing. However, this also means that steady-state levels in the bloodstream are not achieved until 6 to 8 weeks after a consistent dose.
6 to 8 weeks to steady state.
Right. Therefore, any dosage changes need to be adjusted slowly, with serum TSH and free thyroxine levels measured before making further adjustments to avoid transient, misleading serum alterations. Children, of course, also require careful monitoring for normal growth and development as their bodies change so rapidly.
What's the approach for initiating therapy, especially for different patient populations, like older patients or those with heart conditions? Do you start low?
In younger patients or those with very mild disease, full replacement therapy can often be started immediately. However, for older patients over 50 without known cardiac disease, a starting dose of 50 millicgrams is a common, conservative choice. It's absolutely imperative for patients with long-standing hypothyroidism or older patients with underlying cardiac disease to start with much smaller dosages, typically 12.5-25 millicgram for 2 weeks, and then increase slowly by 12.5-25 millisecond d every 2 weeks.
Start low, go slow, especially with heart disease.
Exactly. The goal here is to avoid provoking cardiac events. The heart is extremely sensitive to circulating thyroxine levels, so if symptoms of angina pectoris or cardiac arrhythmia develop, the dosage must be stopped or reduced immediately to prevent serious complications like a myocardial infarction.
What are the signs of too much thyroxine or thyroxine toxicity once a patient starts treatment? What should they look out for?
In children, signs of toxicity can include restlessness, insomnia, and accelerated bone maturation and growth, which can lead to premature fusion of growth plates. For adults, symptoms manifest as increased nervousness, heat intolerance, episodes of palpitations and tachycardia, or unexplained weight loss despite adequate caloric intake. Basically, symptoms of hyperthyroidism.
Right, tipping over into hyper.
Yeah. If these symptoms are present, it's vital to monitor serum TSH and FT4 levels to confirm whether they are indeed due to excess thyroxine. Chronically overtreating with T4, particularly in elderly patients, carries a significant and proven risk of increasing atrial fibrillation and accelerating osteoporosis, leading to bone fragility.
Let's address some special challenges in managing hypothyroidism. First, myxedema and coronary artery disease. This sounds like a tightrope walk for clinicians. How do you handle that combination?
It is indeed a delicate balancing act. Myxedema, which is severe, long-standing hypothyroidism, often occurs in older individuals who may also have underlying coronary artery disease. In this situation, the body's profoundly low thyroid hormone levels paradoxically protect the heart by significantly reducing its metabolic demands and oxygen consumption.
Low levels protect the heart. Wow.
Yeah, in a way. Correcting myxedema too quickly can dramatically increase the heart's workload, potentially provoking angina, atrial fibrillation, or even a myocardial infarction. So correction must be done very cautiously and gradually. If coronary artery surgery is indicated, it should typically be performed before significant thyroxine administration to allow the heart to recover its blood supply first.
And what about myxedema coma? That sounds like a dire, life-threatening emergency. What is it exactly?
Myxedema coma is indeed a profound medical emergency and represents the end state of untreated severe hypothyroidism. It's characterized by a progressive collapse of all body functions associated with weakness, stupor, severe hypothermia, dangerously slowed breathing, hypoventilation, low blood sugar, hypoglycemia, low sodium levels, hypernatremia, water intoxication, shock, and can rapidly be fatal. It mandates immediate, vigorous intensive care unit management, often requiring tracheal intubation and mechanical ventilation to support breathing. Intravenous fluids must be given cautiously to avoid worsening water intoxication.
How do you treat myxedema coma given its severity? What's the immediate plan?
Patients with myxedema coma have a large pool of empty T3 and T4 binding sites that must be filled. The treatment of choice is a loading dose of intravenous levothyroxine, usually 300-400 milligram initially, followed by 50-100 milligram daily.
IVT4 loading dose. Okay.
Intravenous T3 liothyronine can be added, 520 milligram initially, then 2.5-10 milligrams every 8 hours for a faster onset of action, but is more cardiotoxic and harder to monitor due to its short half-life. Lower doses of both T4 and T3 are carefully considered for smaller or older patients or those with cardiac disease or arrhythmias. Intravenous hydrocortisone is also crucial, as associated adrenal or pituitary insufficiency can worsen the crisis. Importantly, opioids and sedatives should be used with extreme caution due to the patient's increased sensitivity to depressants.
Hypothyroidism during pregnancy is another critical area. How is it managed, especially given the profound impact on the developing fetus? What needs to happen?
Hypothyroid women often experience anovulatory cycles and infertility until they achieve a euthyroid state with treatment. Crucially, in a pregnant hypothyroid patient, adequate daily thyroxine dosage is absolutely essential because early fetal brain development is entirely dependent on maternal thyroxine, especially in the first trimester, before the fetal thyroid is fully functional.
Fetal brain needs maternal T4 early on.
Critically, many hypothyroid patients require a significant increase in their thyroxine dose, often about 25-30% above their pre-pregnancy dose, to normalize their serum TSH during pregnancy. A practical tip is to advise women to take 1 extra dose of their current thyroxine tablet twice a week as soon as they know they are pregnant.
Extra dose twice a week.
It's also vital to ensure her thyroxine dose is separated from prenatal vitamins and calcium by at least 4 hours to avoid absorption interference. The monitoring goals are to maintain TSH between 0.1 and 3.0 MIUL with specific trimester ranges and total T4 at or above the upper range of normal.
What about subclinical hypothyroidism? It seems to be quite common, but is it always treated? High TSH, normal hormones?
Subclinical hypothyroidism is defined as an elevated TSH level, but with otherwise normal thyroid hormone levels. It occurs in 4–10% of the general population, and notably up to 20% in women over 50.
20% of older women. Wow.
Yeah. Management is individualized, but the consensus from most expert thyroid organizations is that thyroid hormone therapy might be considered for patients with TSH levels consistently above 10 MIUL, despite some conflicting outcomes from studies regarding its universal benefit. For lower TSH elevations, for example, between 4 and 10 MIUL, close monitoring of symptoms and TSH is often deemed more appropriate than immediate treatment unless symptoms are present.
And if hypothyroidism is caused by a drug, as you mentioned earlier, what do you do then?
Drug-induced hypothyroidism, caused by various medications listed in sources like Table 38-3, is generally managed with levothyroxine therapy if the offending agent cannot be stopped or needs to be continued for another critical condition. For example, with amiodarone-induced hypothyroidism, levothyroxine therapy may be necessary even after the amiodarone is discontinued due to its very long half-life, which means it stays in the body for a long time.
We've delved deep into hypothyroidism. Now let's swing back to the other side of the spectrum. Hyperthyroidism, also known as thyrotoxicosis. This is when tissues are exposed to dangerously high levels of thyroid hormone. Remind us of the key symptoms again.
That's right. If we contrast it with hypothyroidism, hyperthyroidism manifests with a constellation of symptoms that are essentially the opposite. You'll observe warm, moist skin, excessive sweating, heat intolerance, and fine, thin hair that might shed easily. Cardiovascularly, there's a markedly increased heart rate, stroke volume, and cardiac output, with risks of arrhythmias like atrial fibrillation and even angina. The central nervous system shows nervousness, hyperactivity, and agitation, while the GI system speeds up, leading to increased appetite and more frequent bowel movements. Overall metabolism is ramped up, leading to a negative nitrogen balance and often unexplained weight loss despite increased food intake. It's like your body is running a marathon constantly.
And the most common form of hyperthyroidism is Graves' disease, right? Driven by that antibody.
Correct. Graves' disease, also known as diffuse toxic goiter, is the most common form of hyperthyroidism. It's an autoimmune disorder where a defect in suppressor T lymphocytes causes other immune cells, B lymphocytes, to synthesize TSH receptor-stimulating antibodies, or TSHR-ABSTIM, also called TSI. This antibody binds directly to and activates the TSH receptor in the thyroid cell membrane, constantly stimulating the thyroid cells to grow and produce hormones, irrespective of the body's needs.
Are there specific risk factors that make someone more likely to develop Graves' disease? Genetics or environment?
Genetics play a significant role, with a high frequency of specific HLA types observed in different populations. Beyond genetics, external factors like the postpartum state, cigarette smoking, and both significant physical and emotional stress are also known to increase the development of these stimulating TSHR antibodies. Unfortunately, spontaneous remission of Graves' disease is rare, meaning many patients require long-term antithyroid therapy or definitive intervention.
How do you diagnose Graves' disease in the lab, given all we've learned about thyroid tests? What confirms it?
In most cases, laboratory diagnosis reveals elevated T3, T4, FT4, and FT3 levels, coupled with a distinctly suppressed TSH, often undetectable, because the pituitary is trying to turn off the overactive thyroid.
High hormones, low TSH.
Right. Radioiodine uptake is typically markedly elevated, indicating an overactive gland avidly taking up iodine. And crucially, the presence of antithyroglobulin, thyroperoxidase, and especially TSHR-ABSTIM antibodies usually confirms the diagnosis of Graves' disease specifically.
Once diagnosed, what are the primary approaches to managing Graves' disease? What are the main treatment pillars, the big three?
There are three main methods for controlling hyperthyroidism, though it's important to note that none of them directly alter the underlying autoimmune pathogenesis of Graves' disease itself. These are, first, antithyroid drug therapy, which blocks hormone production; second, destruction of the gland with radioactive iodine; and third, surgical thyroidectomy, which involves removing part or all of the gland. The choice depends on many factors, including patient age, gland size, severity, and patient preference.
Let's start with antithyroid drug therapy. Who are the ideal candidates for this approach? When do you choose drugs first?
Drug therapy is most useful for younger patients, those with smaller glands, and individuals with milder disease. The drugs of choice are methimazole, which is generally preferred, or propylthiouracil, PTU. The therapy is typically continued for an extended period, usually 12-18 months, in hopes that spontaneous remission will occur.
Hoping for remission.
Right. Its main advantage is that it's the only therapy that leaves the thyroid gland intact. However, a significant disadvantage is the high relapse rate, 50-60%, once the therapy is stopped, meaning many patients will become hyperthyroid again.
So why is methimazole preferred over PTU for Graves in most cases? You mentioned safety and dosing.
Methimazole is preferred in most cases, except in early pregnancy and thyroid storm, because it carries a lower risk of serious liver injury and, importantly, can be administered once daily. This once-daily dosing significantly improves patient adherence. Therapy usually begins with divided doses, then shifts to a single daily maintenance dose once the patient becomes clinically euthyroid. For instance, an initial dose of 20-40 milligrams of methimazole for 4-8 weeks, then tapering to 5-50 milligrams daily for maintenance. For PTU, it's typically 100 and 150 milligrams every 6 to 8 hours initially, then reduced to 50-150 milligrams once daily.
You mentioned PTU has an additional benefit, which makes it particularly useful in severe cases like thyroid storm, that T4 to T3 blocking.
Yes, that's a key distinction. In addition to inhibiting iodine organification, PTU also uniquely inhibits the peripheral conversion of T4 to T3. This means it brings the level of activated thyroid hormone down more quickly than methimazole, which can be a critical advantage in acute severe cases like thyroid storm. For monitoring, the best clinical guide to remission is often a reduction in the size of the goiter, alongside regular laboratory tests of serum FT3, FT4, and TSH levels.
And the adverse reactions for these drugs remind us of the key things for a patient to watch out for, especially the serious ones like granulocytosis.
We covered these earlier, but it bears repeating due to their importance. Minor reactions like skin rashes can often be managed with antihistamines. But the more severe reaction, a granulocytosis, requires immediate attention. Patients must be instructed to discontinue the drug and seek immediate medical care if they develop a sore throat or high fever, as these can be signs of a dangerously low white blood cell count. This would be followed by a white blood cell count and differential, and appropriate antibiotics if needed. Any significant elevations in liver transaminases, 2 to 3 times the upper limit of normal, also warrant stopping therapy due to the risk of severe liver injury.
What about thyroidectomy? When is surgery the treatment of choice for hyperthyroidism? For whom?
A near-total thyroidectomy is often the treatment of choice for patients with very large glands, or those with toxic multinodular goiters, or in cases where other treatments have failed or are contraindicated. Before surgery, patients are typically treated with antithyroid drugs until they are euthyroid, usually for about 6 weeks, to reduce surgical risks. Additionally, for 10-14 days prior to surgery, they receive a saturated solution of potassium iodide, 5 drops twice daily.
That pre-op iodine again?
Yes. This iodide preparation helps to diminish the gland's vascularity and fragility, which significantly simplifies the surgery and reduces bleeding. It's important to note that about 80–90% of patients will require lifelong thyroid supplementation after a near-total thyroidectomy, as most of their thyroid tissue will have been removed.
And radioactive iodine, REI. When is that preferred, and how do you prepare a patient for it, especially if they're older or have heart issues?
RAI, utilizing 131I, is the preferred definitive treatment for most patients over 21 years of age, often chosen for its ease and effectiveness. For patients without heart disease, the therapeutic dose, typically 80–120 μs of estimated thyroid weight, can be given immediately. However, for patients with underlying heart disease, severe thyrotoxicosis, or elderly patients, it's advisable to treat them with antithyroid drugs, preferably methimazole, until they are euthyroid before RAI administration. This reduces the risk of worsening symptoms from the transient hormone release that can occur after RAI.
How is that pre-treatment managed in terms of timing, stopping and starting the methimazole around the RAI?
The methimazole should be stopped for 2–3 days before RAI is administered to ensure maximal 131I uptake, as antithyroid drugs can interfere with RAI retention in the gland. It can then be restarted 3–5 days later once the RAI has been absorbed, and gradually tapered over 4–6 weeks as thyroid function normalizes. Iodides, crucially, should be avoided during this entire period before RAI to ensure maximal 131I uptake, as non-radioactive iodide would compete for uptake. The gland usually shrinks, and the patient becomes euthyroid or hypothyroid within 6–12 weeks. If the response is insufficient, a second dose may be required after 3 months. Hypothyroidism is a very common outcome, occurring in about 80% of patients following RAI, necessitating prompt lifelong replacement with oral levothyroxine. Regular monitoring of serum FT4 and TSH levels is essential after RAI.
What about using other agents to help manage symptoms during treatment for hyperthyroidism, before the primary treatments fully kick in, those adjuncts?
These are called adjuncts to antithyroid therapy, and they're invaluable for symptomatic relief. During the acute phase of thyrotoxicosis, beta-adrenoceptor blocking agents without intrinsic sympathomimetic activity are highly appropriate for symptomatic patients, especially those aged 60 or older with heart rates over 90 beats per minute or with underlying cardiovascular disease. Propranolol, typically 20–40 milligrams orally every 6 hours, or metoprolol, 25–50 milligrams orally every 6–8 hours, are commonly used to control the rapid heart rate, hypertension, and atrial fibrillation. These are gradually withdrawn as serum thyroxine levels return to normal with the primary antithyroid treatment.
What if beta blockers aren't an option for a patient, say, because they have asthma? Are there alternatives for symptom control?
If beta blockers are contraindicated, for example in patients with severe asthma or heart failure, diltiazem, 90–120 milligrams 3 or 4 times daily, a calcium channel blocker, can be used to control tachycardia. dihydropyridine calcium channel blockers may be less effective for this specific purpose. Supportive care is also critical for all hyperthyroid patients, including ensuring adequate nutrition and vitamin supplements due to the hypermetabolic state. Other medications like barbiturates can accelerate T4 breakdown through hepatic enzyme induction and act as sedatives, while bile acid sequestrants like cholestyramine can rapidly lower T4 levels by increasing its fecal excretion, particularly useful in severe cases where rapid reduction is needed.
Let's quickly touch on toxic uninodular goiter and toxic multinodular goiter. How do these present, and what's the typical management, as they're a bit different from Graves'? Are they common?
These forms of hyperthyroidism commonly occur in older women with nodular goiters. Clinically, free thyroxine levels might be moderately elevated or even occasionally normal, but FT3 or T3 levels are strikingly elevated as the nodules produce predominantly T3.
Mostly T3 from the nodules.
Okay, for a single toxic adenoma, uninodular goiter, either surgical excision or radioiodine therapy are effective and definitive treatments. Toxic multinodular goiter, typically associated with a large lumpy goiter, is usually best treated by preparing the patient with methimazole, or PTU, to get their thyroid levels under control, followed by subtotal thyroidectomy, surgical removal of most of the thyroid gland.
And what about subacute thyroiditis? How does this type of transient thyrotoxicosis occur, and is it treated differently? It sounds temporary.
Subacute thyroiditis is a temporary form of thyrotoxicosis caused by the destruction of thyroid parenchyma, often during a viral infection. This destruction leads to the transient release of large amounts of stored thyroid hormones from the damaged cells.
Like a leak from damage.
Exactly. Similar states can also occur in patients with Hashimoto thyroiditis or as a result of certain drug-induced dysfunctions, such as those caused by immune checkpoint inhibitors or amiodarone, often before the onset of hypothyroidism. These episodes are often termed spontaneously resolving hyperthyroidism because they typically get better on their own.
So how is it managed since it's temporary? Do you use the same drugs?
Management is usually supportive rather than directly targeting hormone synthesis. Beta-adrenoceptor blocking agents like propranolol can be used to control tachycardia and other sympathetic symptoms. Aspirin or nonsteroidal anti-inflammatory drugs, NSAIs, can effectively alleviate local pain and fever, which are common with the inflammation. In severe cases with significant inflammation and pain, corticosteroids may be necessary to reduce the inflammatory response and hasten recovery.
Now let's talk about some specific special problems in hyperthyroidism management, starting with thyroid storm, which sounds incredibly serious and life-threatening. What exactly is it?
Thyroid storm, or thyrotoxic crisis, is indeed a profound, life-threatening, acute exacerbation of all thyrotoxicosis symptoms, often precipitated by infection, surgery, or other acute stressors. It requires mandatory, vigorous management in an intensive care unit. For cardiovascular control, high-dose oral or intravenous propranolol or esmolol, the short-acting beta blocker, is essential to manage severe manifestations like extreme tachycardia, hypertension, and atrial fibrillation. If beta blockers are contraindicated, say due to severe heart failure or asthma, diltiazem can be used orally or intravenously to control the rapid heart rate.
How do you specifically stop the massive hormone surge in the thyroid storm? What drugs target the thyroid itself?
To block hormone release from the gland, saturated solution of potassium iodide is given, usually 5 drops orally every 6 hours. But crucially, this must start 1 hour after thioamides have been administered to prevent the iodide from being used to make more hormone.
Give the thiamide first, then iodide. Got it.
Right. To rapidly reduce new hormone synthesis, propylthiouracil is typically given in a large loading dose, 500,000 milligrams, followed by 250 milligrams orally every 4 hours. If oral administration isn't possible, a rectal formulation of propylthiouracil or methimazole can be prepared and administered. PTU is often preferred here because of that extra T4 to T3 blocking effect.
And is there anything else to help protect the patient from shock or further hormone conversion in such a critical state? Other supports?
Yes, absolutely. Hydrocortisone, typically 50 milligrams intravenously every 6 hours, is crucial. It helps protect the patient against shock and also, importantly, blocks the peripheral conversion of T4 to T3, rapidly reducing the level of the most potent thyroactive material in the blood. Supportive therapy is also vital for controlling fever, managing heart failure, and addressing any underlying disease that might have precipitated the storm. In very rare severe cases that don't respond, oral bile acid sequestrants, plasmapheresis, or peritoneal dialysis have been used to rapidly lower circulating thyroxine levels.
What about ophthalmopathy, the challenging eye disease often seen with Graves'? What's new in its treatment? Anything promising?
Ophthalmopathy, the eye disease characteristic of Graves, is attributed to the presence of TSH receptors and IGF-1R in orbital fibrocytes, the cells around the eyes. While severe ophthalmopathy is rare, it's notoriously challenging to treat. It's also important to note that there's a 15–20% risk of aggravating severe eye disease following radioactive iodine therapy, especially in smokers.
RAI can worsen eyes.
It can, yeah, especially in smokers. Management requires effective treatment of the underlying thyroid disease, often through total surgical excision or 131I ablation, combined with anti-inflammatory therapies. Local therapies like elevating the head during sleep to reduce periorbital edema and artificial tears for corneal drying are also helpful. Smoking cessation is absolutely crucial to prevent progression and improve outcomes. For severe acute inflammation, prednisone tapering can be effective.
And you mentioned a new cutting-edge treatment for ophthalmopathy that's been a game changer. What was that called again?
Yes, teprotumumab, Tepezza, is a significant breakthrough. It's a monoclonal antibody that targets IGF-1R, and it's administered as a series of 8 intravenous infusions once every 3 weeks.
Teprotumumab. Okay.
Clinical trials have shown it can significantly reduce eye bulges, pain, swelling, and double vision for many patients. If these therapies fail or are contraindicated, posterior orbit irradiation may offer improvement. Surgical decompression of the orbit is reserved for threatened vision loss, and further eyelid or eye muscle surgery may be necessary for residual problems after the acute phase subsides.
And the skin condition dermopathy, how is that treated?
Dermopathy, also known as pertibial myxedema, a localized skin thickening, usually responds well to potent topical corticosteroids applied to the involved area and covered with an occlusive dressing to enhance absorption.
Let's discuss thyrotoxicosis during pregnancy. What's the ideal scenario here, and what are the drug choices if it happens during pregnancy?
Ideally, women of childbearing age with severe thyroid disease should undergo definitive therapy, either 131I or subtotal thyroidectomy prior to pregnancy. This helps avoid acute exacerbations during pregnancy or after delivery. If thyrotoxicosis develops during pregnancy, radioactive iodine is strictly contraindicated due to its placental passage and potential to injure the fetal thyroid, leading to congenital hypothyroidism.
So what drugs are safe to use for the mother during pregnancy? Which thioamide?
During the first trimester, propylthiouracil, PTU, is the drug of choice due to its lower perceived teratogenic risks compared to methimazole, especially regarding specific malformations. However, to avoid PTU's black box liver damage risk, it's generally recommended to switch to methimazole for the remainder of the pregnancy, usually after the first trimester is complete.
PTU first trimester, then switch to methimazole.
Right. It's crucial to keep the PTU dose minimal, less than 300 milligrams per day, to avoid inhibiting fetal thyroid function and causing fetal goiter or hypothyroidism. Alternatively, a subtotal thyroidectomy can be safely performed during the mid-trimester if medication isn't working or tolerated, but the patient will then require a lifelong thyroid hormone supplementation afterwards.
What about neonatal Graves' disease? Can babies actually be born with this condition? How does that happen?
Yes, neonatal Graves' disease can occur in newborns either due to the passage of maternal TSHR stim across the placenta, stimulating the neonate's thyroid gland, or, more rarely, through genetic transmission of the trait. Diagnosis involves finding elevated free T4, markedly elevated T3, and a low TSH in the infant, in striking contrast to the normal infant's transiently elevated TSH at birth. TSHR abstim is usually found in both the infant's and the mother's serum, confirming the cause.
And how is it treated in such tiny patients? Is it permanent?
It's caused by maternal antibodies. The disease is usually self-limited, subsiding over 4–12 weeks as the maternal antibody levels in the infant naturally fall. However, treatment is absolutely necessary due to the severe metabolic stress the infant experiences. Therapy typically includes propylthiouracil, 5 to 10 millicurograms daily, Lugol solution, 1 drop every 8 hours for its iodide content, and propranolol, 2 milligrams daily, to control symptoms. For very ill infants, oral prednisone may be added to help block T4 to T3 conversion. These medications are gradually reduced as the infant's clinical picture improves and maternal antibodies clear.
What about subclinical hyperthyroidism? This means suppressed TSH but normal thyroid hormones. Is it treated? What's the concern?
Subclinical hyperthyroidism is defined by a suppressed TSH level, meaning below the normal range, in conjunction with otherwise normal thyroid hormone levels. The primary concern here, and a crucial insight for professionals, is cardiac toxicity, particularly an increased risk of atrial fibrillation, especially in older individuals or those with underlying cardiac disease.
AFib risk.
The consensus among thyroid experts is that treatment for hyperthyroidism is generally appropriate when TSH is less than 0.1 MIUL, while for less severe TSH suppression, close monitoring and observation are often sufficient, weighing the risks versus benefits of treatment.
Finally, amiodarone-induced thyrotoxicosis. This is a tricky one because amiodarone itself affects iodine and the thyroid in multiple ways, right?
It is indeed a complex clinical challenge. Amiodarone, a commonly used antiarrhythmic drug, can paradoxically cause hyperthyroidism in about 3% of patients, in addition to causing hypothyroidism, as we mentioned earlier. There are two main types. Type I is iodine-induced, typically occurring in people with underlying thyroid disease like multinodular goiter or Graves', and it responds best to thioamides.
Type I is iodine-induced. Treat with thioamides.
Right. Type 2 is an inflammatory thyroiditis, seen in patients without underlying thyroid disease caused by hormone leakage due to direct thyroid cell damage from the amiodarone, and this type responds best to glucocorticoids.
Type 2 is inflammatory. Treat with steroids.
Correct. The complexity arises because it's not always easy to differentiate between the two types clinically, so thioamides and glucocorticoids are often co-administered. Improvement is slow, even if amiodarone is stopped, given its very long half-life of up to several months.
We've covered a huge amount of ground on thyroid conditions and their treatments. Now, let's quickly touch on a couple of other related topics that often come up. First, non-toxic goiter. What is that?
Non-toxic goiter is essentially an enlargement of the thyroid gland that occurs without excessive thyroid hormone production. This enlargement is often due to chronic TSH stimulation, which happens when the thyroid isn't producing adequate hormone levels for the body's needs, leading the pituitary to release more TSH to try and stimulate it.
So enlarged gland, but normal function usually. What causes it?
The most common cause worldwide is iodide deficiency. In the United States, however, Hashimoto thyroiditis is the leading cause. Other etiologies include rare gene mutations involved in hormone synthesis, certain dietary goitrogens, substances in food that interfere with thyroid function, and even benign neoplasms.
How is non-toxic goiter typically managed? What do you do about it?
If the goiter is due to iodide deficiency, prophylactic iodide administration, typically 150-200 milligram daily, often through iodized salt or iodate in flour, is the best approach to normalize function. If it's from dietary goitrogens, the treatment involves identifying and eliminating the goitrogen from the diet or adding enough thyroxine to suppress TSH stimulation. In cases of Hashimoto thyroiditis or dyshormonogenesis, adequate thyroxine therapy around 150-200 milligram orally daily will suppress pituitary TSH, which leads to a slow regression of the goiter size and, importantly, corrects any underlying hypothyroidism.
And finally, thyroid neoplasms or thyroid cancer. How are these diagnosed and managed? What's the approach?
Thyroid neoplasms can be either benign adenomas or malignant carcinomas. The primary diagnostic test for thyroid nodules is a fine needle aspiration, FNA biopsy, and careful cytologic examination of the cells.
FNA biopsy is key.
Yes. Benign lesions are usually monitored for growth or symptoms of local obstruction, which would then mandate surgical excision. It's important to note that levothyroxine therapy is not recommended for the suppression of benign nodules, especially in iodine-sufficient areas, as studies haven't shown it to be consistently effective in shrinking them.
What about malignant lesions, thyroid cancer? What's the standard treatment?
Thyroid carcinoma typically requires a total thyroidectomy surgical removal of the entire thyroid gland. In selected instances, this is followed by postoperative radioactive iodine therapy to destroy any remaining thyroid cells or microscopic cancer spread, and then lifelong replacement with levothyroxine to prevent hypothyroidism and suppress TSH, which can stimulate cancer growth. For evaluating recurrence of certain thyroid malignancies after initial treatment, a common approach historically involved withdrawing thyroxine replacement for 4 to 6 weeks to allow TSH levels to elevate, though this leads to temporary and unpleasant hypothyroidism. A rise in serum thyroglobulin, which is a tumor marker produced by thyroid cells, including cancer cells, or a positive 131I scan when TSH is elevated, suggests recurrence.
Is there an alternative to this induced hypothyroidism for recurrence evaluation, something that makes it easier on the patient? Because stopping T4 sounds miserable.
Yes, there is an excellent and patient-friendly alternative, recombinant human TSH, branded as Thyrogen.
Thyrogen, okay.
It can be administered intramuscularly for 2 days to produce comparable TSH elevations without requiring the patient to discontinue their thyroxine. This avoids the unpleasant symptoms of hypothyroidism during the testing period. A rise in serum thyroglobulin or a positive 131I scan following thyrogen administration would also indicate a recurrence of the thyroid cancer, allowing for earlier detection and intervention.
All right, this has been an incredible deep dive, really packed with detailed information that truly gets us to that elite professional level of understanding. Now it's time to bring it all together by revisiting JP's case study, but this time, from your perspective, armed with all the knowledge we've just acquired, let's put it all together for her.
Excellent. Let's revisit JP, our 33-year-old listener. Her initial complaints of fatigue, weight gain, cold intolerance, and muscle weakness, contrasted with her past hyperthyroid symptoms of feeling hot and difficulty sleeping, perfectly aligned with the diagnosis of hypothyroidism. Her lab results unequivocally confirm this, a TSH level of 24.9 URI/UML, which is markedly elevated above the normal range of 0.45–4.12 URI/UML.
Way high TSH.
And a free thyroxine level of 8 pmol, which is low compared to the normal range of 10–18 pmol. This combination points directly to inadequate thyroid hormone replacement, likely due to her history of radioactive iodine therapy, which definitively destroyed her thyroid gland, making her permanently hypothyroid.
And her past management of hyperthyroidism. How do we view that now? With this knowledge, was it appropriate?
Her initial methimazole treatment for hyperthyroidism was appropriate and, in fact, preferred over PTU, given its longer duration of action and improved safety profile for long-term use. The subsequent radioactive iodine therapy was also a very reasonable and effective strategy for definitive treatment of her hyperthyroidism, especially considering her self-reported poor adherence to medication, which is common with chronic conditions, and her stated future pregnancy plans. RAI offers a definitive solution that removes the need for daily adherence to antithyroid drugs.
So she was treated correctly for hyperthyroidism. The problem now is her current hypothyroidism, specifically that her levothyroxine isn't working as it should be, despite being on what seems like a standard dose. This is where our deep dive into drug interactions becomes the undeniable aha moment for JP's case, right? This explains everything.
Precisely. The core issue is indeed inadequate levothyroxine replacement, despite being on what appears to be a sufficient dose. Our detailed knowledge of pharmacokinetics and common drug interactions provides the direct answer, transforming this baffling case into a clear diagnostic picture. JP is taking calcium carbonate 3 times daily for osteoporosis.
Calcium.
Calcium, as we just learned, is a well-known interfering agent that can significantly impair T4 absorption from the gut by binding to it and preventing its uptake. She's also on omeprazole for heartburn, which is a proton pump inhibitor.
The PPI.
Proton pump inhibitors dramatically reduce gastric acidity, and since T4 absorption is highly sensitive to gastric pH and requires an acidic environment to dissolve properly, omeprazole can severely impair T4 absorption by making the stomach less acidic.
So, those 2 common medications are directly sabotaging her essential levothyroxine, preventing it from ever really getting into her system and doing its job. What are the professional recommendations for JP then to finally get her thyroid levels balanced? What does she need to do?
First and foremost, we must emphasize the critical importance of optimal levothyroxine administration. She needs to take her levothyroxine on an empty stomach, ideally 30–60 minutes before breakfast, or at bedtime, at least 4 hours after her last meal. Crucially, she must separate her levothyroxine dose from her calcium carbonate administration by at least 4 hours.
4 hours separation from calcium, that's key.
Absolutely key. This will minimize the known interference and maximize absorption. We might even suggest exploring alternative calcium formulations or dosing strategies if possible.
What about the omeprazole, given its impact on absorption? Should she stop it?
The impact of omeprazole should also be addressed. If it's medically feasible for her to stop or change her omeprazole to another class of acid-reducing medication that doesn't affect pH as much, or to address the underlying heartburn directly, then lower thyroxine doses might then be sufficient, as her T4 absorption would likely improve dramatically. We also need a clear monitoring protocol. We would schedule a recheck of her thyroid function tests after 6 to 8 weeks, which is when steady-state levels are achieved with the corrected administration. It's vital to always obtain these blood samples before her morning thyroxine dose to avoid any transient, artificially altered hormone levels that could lead to misinterpretation.
And adherence continues to be an issue. Are there any other options for someone who struggles to take daily pills? Anything else to consider?
For patients with ongoing non-adherence, even with optimized oral timing, once-weekly oral formulations or, in very specific cases, even once-weekly thyroxine injections could be an alternative to consider, though this is less common and usually reserved for profound malabsorption or non-adherence. Finally, given her stated goal of becoming pregnant, we would reiterate the specific TSH targets for pregnancy. Maintain TSH between room point 0.1 and 3.0 MIUL, which is absolutely crucial for optimal fetal brain development. Her current TSH of 24.9 is clearly far from that target, highlighting the urgency and profound importance of these immediate adjustments.
What an incredible journey we've just taken. We started with the subtle shifts in energy and mood that often baffle us, and we've gone all the way to understanding the microscopic mechanisms of iodide metabolism, the intricate interplay of hormones, and the precise diagnostic tools and targeted therapies for both hypothyroidism and hyperthyroidism. You now truly understand the difference between symptomatic relief and definitive treatment, and how something as simple as timing a pill can make all the difference.
You're now equipped with knowledge truly comparable to elite professionals in the field, capable of understanding the nuanced world of thyroid health. You've seen how a tiny gland can orchestrate so much of our body's function, and how even seemingly simple daily habits can profoundly impact complex pharmacology and patient outcomes. It's about connecting those dots, you know.
It's truly eye-opening. As you reflect on this deep dive, consider this provocative thought. Understanding the thyroid's profound influence on almost every body system, what other seemingly disconnected aspects of human health might also be governed by such fundamental, often overlooked biological processes? We encourage you to continue thinking critically about your own health information and always be curious enough to launch your own deep dives.